group of obstructive diseases that we're going to talk about is the chronic obstructive pulmonary diseases, also known as the COPDs. Now, like we mentioned a minute ago, like the COPDs, what's very unique about it, that on the pulmonary function test, if you go and you do the FEV1 over FVC ratio, you're going to have a decrease in 80%, okay? The differences between this and asthma is, of course, asthma, when you give a bronchodilator, normally you should see some improvement in the FEV1 over FVC. However, in the COPDs, you're going to have a non-reversible, meaning after you give the bronchodilator, you're still going to have a decrease in the FEV1 over FVC ratio, okay? Now, there are two types of COPDs. You have emphysema and you have chronic bronchitis, okay? The most common symptom in emphysema and well, really all COPDs is obviously going to be dyspnea. Okay, the patient's going to be dyspnea. Why? Because again, because we have an obstructive disease over here, because you're going to have an obstruction to the airflow, so the patient's going to get less oxygen, and when they get less oxygen, obviously, like we said before, they're going to have dyspnea. Now, one of the ways to compensate, and this is especially important in the COPDs, one of the ways to compensate for decreased oxygen is what we're going to do is basically our respiratory sensors, when they sense this, they're basically going to increase the respiratory rate. Okay, and by increasing the respiratory rate, this goes, and although there's an obstruction and we're bringing less oxygen, but if we increase respiratory rate, we bring in more gas per minute. Therefore, we somewhat try compensating for the low oxygen levels, okay? Now, what's very, very important, and this is extremely important with the COPDs, to check if a patient has a very severe COPD, if the respiratory rate is extremely high, that basically tells us that he has a very chronic low state of hypoxia, and therefore his COPD is very severe. So increased respiratory rate is a sign of severe of COPD. Okay, so that's the first thing we're going to see in these patients. In addition, because you're going to have low levels of hypoxia, what happens is, another way to compensate, specifically in the kidney, the proximal convoluted tubule has these very important cells referred to as oxygen receptors. Okay, now these oxygen receptors, what happens, they're able to basically sense the oxygen content within the blood. Now, when oxygen are, for example, chronically low for too long, what's going to happen is it's going to stimulate these receptors, and these receptors are going to lead to the synthesis and the production of a very important protein known as the erythropoietin. Okay, and erythropoietin will go to the bone marrow, and inside the bone marrow, of course, it's going to stimulate the hematopoietic stem cells, which of course is going to lead to the erythrocyte progenitor cells to be made, and obviously we're going to start producing a lot of red blood cells, okay? And when we have a lot of red blood cells, again, although we're going to have low levels of oxygen over here, but we're going to try compensating by increasing our amount of red blood cells, okay? So we can deliver more oxygen to different tissues. Okay, now, because we have a lot of red blood cells, patients are going to develop, obviously, polycythemia, which means that the patient has increased red blood cell count. And because patients have polycythemia, patients with COPD are referred to as pink puffers. Okay, pink puffers, basically, what happens is when the patient exhales, so he goes like this. It's a prolonged exhale, and his cheeks and his face gets all red and pink. And why does this happen? Obviously, because red blood cells, of course, contain hemoglobin. The more red blood cells, this means the more hemoglobin. And the more hemoglobin, this is going to mean the more red, the more pink the patient's going to get when he's going to be exhaling. And of course, he's going to have a long exhale. Why? Because the patient, when he basically, because it's an obstructive disease, is a problem that air is a very hard time to get out. So to get a lot of air, at least try to get a lot of air out of him, so what he has to do, he has to go and he exhales for a long time, and that's why patients have a very long exhale over here. In addition, because the patient has a hard time, getting air out of his lungs, over time the lungs, obviously, like we mentioned before, are going to be hyperinflated. And of course, if lungs are chronically hyperinflated, this could lead to the patient to have a barrel chest. Okay, so on the physical exam, another thing we could see in a COPD patient is a barrel chest. In addition, because the patient has low levels of oxygen, specifically in the nails, what happens is if the nails and the fingernails are hyperperfused, this can lead to the clubbing of the fingernails. Okay? So that is basically the symptoms and the signs of the COPD. And obviously, in addition, you could also have wheezing, like we mentioned before, in all COPD, in all obstructive diseases. Again, like we said before, you have inspiratory and expiratory wheezing. Inspiratory wheezing, it means that you have a very severe disease. Expiratory wheezing is usually the case. Why? Because we're not going to have that negative pressure in the expiration. Okay. So that are basically the signs and symptoms of all the COPDs. Now emphysema basically, the way we could actually differentiate emphysema from chronic bronchitis, at least history-wise, is in chronic bronchitis, you basically have to have a productive cough. So a productive cough that you need to have at least for 2 to 3 months straight, at least twice a year for 2 years consecutive. Okay, so it's 2-2-2-2, really, or really 2-3-2-2, and once you have this, you have been diagnosed with chronic bronchitis. Okay, but again, this usually is going to be differentiated from emphysema by having the productive cough. While emphysema, you might have some type of cough, but you're not going to have that type of productive cough in chronic bronchitis. Okay, now, of course, by the way, chronic bronchitis is caused by what happens is a person, for example, has, let's say, bronchitis, okay? And the bronchitis is not treated properly. So in the bronchioles over here, basically, you get inflamed over here, and when it gets inflamed, this leads to fibrosis, and of course, this decreases the oxygen, therefore this leads to an obstruction disease, okay? And emphysema, the differences with emphysema is emphysema, you have an obstructive disease, but also the alveoli end up getting damaged, and the alveoli end up getting destroyed, okay? Now, the way we basically, for example, so let's say a patient comes to us, we suspect that he has an obstructive disease. So what we do is, obviously, we take a pulmonary function test, we see that the FEV1 or FVC ratio is low. So what we're going to do next, obviously, we're going to see if this is going to be an asthma or this is going to be a non-reversible COPD disease. So we give our bronchodilator, the bronchodilator goes, and let's say we see that it's not reversible, therefore he has a COPD. Now, how are you supposed to tell if the patient has emphysema or chronic bronchitis? So one of the things that can help you, again, is with the symptoms that a patient may have. By the way, bronchitis can also have all these symptoms as well. But really, what you really have to do with a patient, really to differentiate between chronic bronchitis and emphysema, is you're going to have to do a DLCO, okay? And the DLCO, remember what happens is, let's say this is emphysema and this is chronic bronchitis. In emphysema, what happens with the DLCO, because the alveoli are going to be destroyed within the lungs, what happens is when the patient breathes in carbon dioxide, the carbon dioxide is not going to be diffused properly through the alveoli, and therefore the patient is going to be blowing out more carbon dioxide. Therefore, the DLCO is going to be high. Okay, or for example, if you want to look at DLCO as in actual oxygen transportation, that's going to be low within the lung. Okay, but regarding chronic bronchitis, all you have is an obstruction disease. You have a chronic obstruction disease which is not getting better. However, if you actually look at the alveolar ventilation, that's going to be normal, and therefore this is going to be normal in both patients. Okay, typically it's going to be normal. Now you should note that in chronic bronchitis, usually have some type of destruction to the alveoli. So don't really get confused to think that always in chronic bronchitis you're always going to see normal DLCOs. You can see a mild elevated DLCO, and because you usually have some type of degree of damage to the alveoli, okay? It could be also somewhat elevated, okay? Now, in addition, also COPD, I forgot to mention this before, 90% of COPD patients are going to be smokers, okay? So if the patient is not a smoker, it's 90% of the time is not COPD, okay? Now, one more thing about COPD, and that's really to understand why COPD kills a patient, and that is because it can lead to something which is referred to as cor pulmonale. Okay, cor pulmonale basically is telling us that there's going to have right ventricular failure due to some type of pulmonary cause. Okay, you see, what happens is if, for example, we have an obstructive disease, so within the lung, the pressures within the lung are going to increase, okay? And when the pressure increases within the lungs, the pressures have to compensate by increasing within the pulmonary arteries, okay? And of course, if the pressure increases the pulmonary arteries, the right ventricle has to actually match up with that pressure, so therefore it's going to go under hypertrophy, and of course you're going to get left ventricle hypertrophy, and of course that's eventually going to lead to left ventricle dilation, and eventually that's going to lead to right ventricular dilation, and that's basically going to lead to completely right-hearted failure, and of course you're going to develop eventually congestive heart failure. And that is really how the COPD really kills the patient, okay? So it's very, very important also to understand that any patient diagnosed with a COPD, after we differentiate if he has emphysema or chronic bronchitis, what other tests you have to do, or other workup you have to do, is number one, you have to also do, an EKG to make sure he doesn't have any cardiac problems. In addition, you could also do an echo. to make sure it doesn't have any symptoms of cardiac type of symptoms. He doesn't have any congestive heart failure, no right ventricular hypertrophy, no right ventricular failure. In addition, of course, we do the ABGs as well. Within the ABGs, basically, usually what we see is we see hypercapnia, which is really a high carbon dioxide in blood. So the patient may have a mild respiratory acidosis. Also, this is obviously we see low levels of oxygen, we see hypoxia. Okay, that is really what the ABG is going to show. In addition, obviously, we also do an X-ray. Why we do an X-ray? An X-ray is very important because, like we'll discuss later on, the COPD exacerbations are very, very commonly, most commonly caused by infections. Okay, so very important is after any time patient gets a COPD activation, as well as also we want to just randomly check on a COPD patient. We're going to do an X-ray to see. Number one, it helps us diagnose the bowel chest. It helps us see the the flattened diaphragms as well. But it's also important because it can tell us if the patient has an infection. Okay, and that is really the workup of the COPD. Now, the management of the COPD patients is extremely important. Now, the management, obviously, we can have management in the acute setting and the chronic setting. We're going to first talk about the management in the chronic setting of a COPD patient. Okay, now the first thing you want to do for the patient that has COPD is, number one, you want to fix the smoking problem, okay? Because smoking really exacerbates COPD. It makes it worse, it makes it progressive, it can lead to exacerbations. So the first thing you want to do before you go to any medications is you make sure your patient stops to smoke, okay? You stop the smoking, okay? That's number one. Now, once your patient stops smoking and once you got that covered, then you're going to start going to the medical treatment, okay? Now, the best choice of treatment is going to be the anticholinergics, okay? The anticholinergics, remember we mentioned about the asthma section, isn't so good for asthma because it takes a while to work, but one of the benefits it has, it's a very long-acting, basically a long-acting bronchodilator. So really what you want to do is you want to give, the starting treatment is you want to give the anticholinergics to, of course, lead to the bronchodilation. And when you have dilation, more air obviously gets through. So we fix dyspnea, which means we fix the oxygen level, which means we prevent the cor pulmonale. Okay, remember the treatment is prevent cor pulmonale. Okay, now if the anticholinergics are not working properly, then what we're going to do is we're going to give the patient the long-acting beta agonist. Now, I want you to understand, why don't we just go straight to long-acting beta agonists in the beginning? It's because, again, like I said before, patients usually have some form of cardiac manifestations with cor pulmonale, with COPD. Therefore, beta agonists could go and make the heart work harder, it can make oxygen more, and it can lead to more damage to the heart. So we really want to try avoiding the long-term beta agonists. However, if the patient's anticholinergics are not working properly, then we're going to go and we're going to also add the long-term beta agonist. Okay. Now, if you let's say do both, okay, you give the anticholinergics and you give the long-term beta agonist, and still the patient is not getting better, then what you're going to go is you're going to give something what is known as defiling. Okay. Basically, what this drug is. This drug has really two mechanisms. Number one, it's a phosphodiesterase inhibitor. Basically, by going and inhibiting all the inflammatory mediators, it basically prevents all the inflammatory markers that would normally lead to the obstruction, it will lead to inflammation, it inhibits, let's say, the prostaglandins, the leukotriene, the histamine, and of course, by doing that, we obviously go and we leave a lot more room for now air to flow into the lung, and to go and, of course, perfuse the lung tissues more. We have more oxygen, which means we have less cor pulmonale, and we have less other symptoms over here. Okay, and that is what theophylline really does. Okay, the second thing theophylline does, it also has basically it's an adenosine antagonist. Okay, and this is for the heart, but again, this is not really such important as it's a competitive inhibitor to the phosphodiesterase enzyme. Okay, now what's important about the theophylline, once you give theophylline, you cannot take a patient off it. Not because it's dangerous, but because it does such a good job in increasing and dilating the bronchioles. If you would take a patient off it, he will feel so terrible. He will get such bad dyspnea. Although it really technically doesn't make a person better, it just really relieves the symptoms. But because it works so well, once you give a person on it, you cannot take a person off it. So you always got to be careful before you give him it to make sure he really is going to need it. Okay. But again, of course, try the anticholinergics and the long-term beta agonist before it. Okay. Now, regarding for the oxygen management, actually is a little complicated. Okay, so obviously you're going to be giving home oxygen to the patient. Now, first of all, what are the benefits of home oxygen? Home oxygen, again, we want to give the patient 100% saturated oxygen. Of course, in this house, the best is preferred to use 24 hours a day. A lot of patients can't use it 24 hours a day. Again, we obviously encourage 24 hours a day. If you can't use it 24 hours a day, if you have a choice, let's say the night or the day, the night is going to be better. Why? Because at night, the lungs, and typically we're in a state of hypoxia, therefore we're going to really need the oxygen 100% saturated during the night. So the night is much more key than actually during the day. Okay. Now the home oxygen will be given to patients in two scenarios. The first scenario, we give the patient home oxygen if the patient has any symptoms or signs of poor pulmonality. If he has of this, he automatically gets home oxygen. And the second thing, and the second indication that person gets home oxygen, if his PO2 oxygen content is going to be below 55. If it's below 55, then again, the patient also is going to be sent home with home oxygen. Okay. Now, other things what you need to know about home oxygen is with number one, with exercise. Exercise. Let's say a person says let's say he has a PO2 over 55 and he doesn't have poor pulmonality. Okay, if he's doing exercise and he starts to get fatigue, he starts to get dyspnea, he starts to get a little exacerbated, then what you're going to do is you're going to say, all right, fine, take oxygen only when you exercise. In addition, I forgot to mention about the asthma patient, you could also take albuterol. If as a patient, like we said before, the exercise can actually stimulate the and actually trigger an asthma exacerbation. So we're not going to tell people obviously not to exercise. We'll tell them, all right, just before you exercise, take a little albuterol so you can have a bronchodilator so you won't have that asthma exacerbation. And the same thing applies to the COPD patient with the home oxygen. Also, you obviously will give him the albuterol over here. Okay. Now, okay, so that was about the home oxygen. Okay, the second thing you have to do with a patient with a chronic COPD is you have to make sure that the patients are well vaccinated. What vaccines you're going to be giving your patient? The first one you're going to give is the pneumococcal vaccine. You have to give it to him once. And the second one you're going to give him is you're going to give him the influenza vaccine. And this you have to give him every single year. Okay, and why this is important, because we're going to discuss in a second about the exacerbations of COPD. And most of the times, anytime a patient has exacerbation of COPD, it's most commonly caused by some type of lung infection. Okay, so you have to make sure to really prevent that from happening, because of course that could be life-threatening. Okay. Now the next thing we're obviously going to talk about is the COPD within the acute setting. Okay. Now the COPD exacerbations, again, the most common cause over here is usually an infection, but again, it can be all the other type of things like mold, allergies, heat, cold, exercise, etc. Okay, so the COPD exacerbations. Okay. The first thing you have to understand is that they're all treated the same way. It's really very similar to how the management of asthma exacerbation. Number one, they have all the same symptoms like we mentioned before. The treatment, again, is going to be oxygen, albuterol, and you're going to be giving them steroids eventually. The only difference is this whole thing with the oxygen. You see, what happens is because they have chronic levels of carbon dioxide, so eventually the centers which normally sense carbon dioxide, those centers are eventually going to get desensitized and they're going to shut off. So the only centers really to go and really stimulate the breathing is going to be the low levels of oxygen within their body. Now, if you're going to give them too much oxygen, what's going to happen is, because it's the low oxygen, it's because it's the hypoxia, which is causing their diaphragm to contract every single couple of times a minute. So what's going to happen in these patients, if you increase the oxygen too much, then you could actually start decreasing the respiratory rate. And if you increase the respiratory rate, they could develop a very severe acidosis, and eventually they could even actually cease of having any type of respiratory rate, and of course, then they could die. So you always have to make sure, again, you have to make sure definitely it's not over 95. So you always make sure that the oxygen is never over 95. The best to get it to is about from 92 to 93. Okay, that's the prime where you want to get the oxygen contact within the blood. In addition, what's also different about the COPD exacerbation is when you're treating the patient, after obviously you give the steroids and stuff, you're going to give them antibiotics even though there may be not any signs of infection. Because usually it's an infection that causes COPD exacerbation, you're going to give these patients antibiotics even though the x-ray doesn't show anything, even though it doesn't show fever or anything like that. You're still going to be giving these patients the antibiotics, and that's extremely important. This is very important in management, and what's really different than the asthma exacerbation. Okay, and that is really how we treat the COPD in the acute setting. Okay, now although most COPD patients usually, by the way, I forgot to mention, are usually going to be elderly people, like usually about 70 or 80 years old patients. What happens is let's say I go and I have a patient that has, let's say, I suspect that he has maybe asthma, and I basically do my pulmonary function test, and I find out that he has a COPD problem, but he's only, let's say, 20 or 30. Okay, so if a patient basically comes to you with a COPD, and he's very young, like 20 or 30 or 40, then you have to suspect a very important condition referred to as the alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency. Okay, this is basically an autosomal recessive disorder. What happens is normally the liver is supposed to make a very important protein, which is again, it synthesizes and secretes a protein known as antitrypsin. Now, antitrypsin is supposed to then go to the lungs. Inside the lungs, it basically protects the lungs from all different types of collagenases, protects them from trispin, and anything that basically damages the alveoli. Okay, so normally it protects them, it cancels these things out from destroying our alveoli. Okay, the problem is, what happens is, if patients do not have antitrypsin, what happens is that they're really prone to extensive damage to their alveoli, and a patient will develop emphysema at a very young age. Okay, so it's very important that if a patient has, really, again, it's normally 70 to 80, and a patient has emphysema, let's say when he's under 20 years old, so you have to make sure that you rule out antitrypsin alpha-1 deficiency, of course, by going and you're checking the antitrypsin level. That is obviously how you make the diagnosis. Look for the antitrypsin level, and of course, if it's going to be low, that's going to be your diagnosis. Now, the treatment, there really isn't any specific treatment. If he has a COPD, obviously treat him like any other COPD situation. But again, what you really want to do over here is really prevention. You want to really make sure that he has the proper vitamins. You want to make sure that his immune system is very good. You want to make sure that he's vaccinated properly, because it's the infections which makes our immune cells start releasing more of this garbage, which will damage more. And again, specifically because we don't have any defense mechanisms protecting us from the lung, so that's when we're going to get the severe problems with these patients with alpha-1 antitrypsin deficiency. Okay. Now, there's one more thing I just forgot to mention over here, and that is in the exacerbation, what happens is, if let's say you arrive at the scene, you're an EMT, you arrive at the scene, and if the patient is on home oxygen, so that should already ring a bell that this patient is a severe COPD patient, and if he's having an exacerbation, he most probably has to be hospitalized. In addition, like we said before, if a patient has any type of hemodynamic instability, he has palpitations, arrhythmia, angina, confusion, shortness of breath, not shortness of breath, he's having that either way, but if he has any type of things like acidosis, then that means the patient is severe, and you have to probably intubate the patient, and you definitely you have to really send them to the hospital very quick, okay? Because those patients could really be very severely damaged and injured, okay? And that is really the COPD.